Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical. Today, we are jumping into a deep dive on a scenario that is, frankly, every trauma surgeon's nightmare.
Oh, absolutely. I mean, it's the ultimate high-stakes, low-frequency situation you can face in the Bay.
Right. We are unpacking the management of upper airway and tracheobronchial injuries, pulling directly from the definitive chapter by Louis G. Fernandez, Scott H. Norwood, and John D. Byrne. And just to set the stage for you listening, these injuries account for a mere 0.03% of major trauma admissions.
Which is an incredibly small number, but the lethality is just off the charts. Like, 80% of these victims die at the scene before EMS even arrives.
Yeah, that stat is just brutal. And for the 20% who actually make it through your doors, about 21% of them will die within 2 hours of hospitalization.
Right, because you don't get the luxury of time. You're dealing with a patient who is actively asphyxiating.
Exactly. So our mission today, for all you U.S.-trained trauma and surgical critical care surgeons out there, is to break down the exact algorithms. When do you observe? When do you intubate over a scope? And when do you absolutely have to crack the chest?
It's a complete pivot from the standard ATLS algorithms we all drill.
Hmm.
You have to understand the anatomy first, though, to even grasp why these injuries are so rare to begin with.
Let's talk about that, because the text really paints the airway as this highly fortified vault, right?
It really is. The architecture is just a masterclass in deflective armor. Anteriorly, you have the mandible jutting out, and then the sternum acting as this massive bony shield for the intrathoracic part.
Right, and posteriorly, you've got the entire cervical and thoracic spinal column anchoring it all down.
But the real lifesaver in blunt trauma isn't actually the bone. It's the tissue elasticity. I mean, the airway is suspended in this complex web of fascial planes and strap muscles.
So it basically just shifts and glides away from the kinetic impact.
Exactly. Which is why penetrating mechanisms so heavily outnumber blunt trauma here. To actually breach that mobile tube, you usually need a high-velocity projectile or a blade.
Something that just bypasses the armor entirely. So let's map out that breach, starting at the oral cavity. Surgically, you really have to view this as a bounded vault.
Yeah, you've got the lips anteriorly, the anterior consular pillars posteriorly. The roof is your hard and soft palate.
And the floor is that mucosa overlying the sublingual and submandibular glands, right, where the Stenson and Wharton ducts sit.
Right, it's the alternate path to the nasopharynx. But things get so much more complicated as we move back into the pharynx. We generally divide this into 3 surgical zones.
Right, starting with the nasopharynx from the posterior choanae down to the soft palate, and then the oropharynx, which is what we see from the soft palate down to the vallecula.
And that vallecula is a space every surgeon knows from intubation, that little pouch between the tongue base and the epiglottis.
But the real red alert area in penetrating trauma is the hypopharynx, isn't it?
Oh, without a doubt. It starts right below the tip of the epiglottis and goes all the way down to the cricopharyngeus muscle, where it becomes the cervical esophagus.
It's just a massive anatomical bottleneck. You've got the epiglottis in front and those piriform sinuses laterally.
Yeah, so if a bullet or a knife crosses that specific zone, you are never just dealing with an airway problem.
You're hitting the digestive tract and those major cervical vessels all packed in there together.
Exactly. An isolated hypopharyngeal injury is basically a myth. It's a combined injury until you physically prove otherwise.
Wow, okay. And sitting right in front of that space is the laryngeal valve. The text points out that the larynx is so much more than just a tube for air.
Right. It's a dynamic respirator, a communication organ, and most importantly, an aspiration barrier. It lets us close the glottis and build intrathoracic pressure.
Which is how we generate a cough or a Valsalva maneuver. And the skeletal framework hanging there is just highly specialized.
It hangs right off the hyoid bone, tethered by the epiglottis and strap muscles. Then you have the thyroid cartilage acting as the anterior shield.
And that's where the vocal folds attach. But the really critical structure, surgically speaking, is the cricoid cartilage.
Yes, the cricoid is the absolute keystone. It articulates with the thyroid and the arytenoid cartilages.
And those arytenoids are what glide along the back of the cricoid to move the vocal folds, right?
Correct. But the defining feature of the cricoid, and why it's a surgical disaster if it breaks, is that it's the only complete 360-degree cartilaginous ring in the whole respiratory tract.
Right, because everything below that, all the tracheal rings are just U-shaped with that soft membranous wall in the back.
Exactly. So if you just fracture the thyroid cartilage, you might get a hematoma or vocal dysfunction. But if you crush that cricoid ring, you lose the foundational support.
The entire lumen just collapses in on itself.
It does. And then we have to talk about the neurological wiring, because that's a huge trap here. The vagus nerve branches control everything.
Right, and as residents, the instinct drilled into us is always preserve the nerves.
Yeah, so you've got the superior laryngeal nerve branching high up, giving sensation to the glottis and motor function to the cricothyroid muscle.
Which tenses the vocal cords. But the one that really haunts neck explorations is the recurrent laryngeal nerve.
Oh, absolutely. It gives sensation to the subglottis and runs the intrinsic laryngeal muscles. But its anatomical path puts it right in the crosshairs of trauma.
Because it branches off the vagus way down in the mediastinum, right?
Right. On the right side, it hooks under the subclavian. On the left, it loops under the aorta. And then it ascends straight up that tracheoesophageal groove.
And I mean, in a nice, clean, elective thyroidectomy, finding it is standard. But in a trauma neck with a massive hematoma...
It's ghost in a minefield. You were looking at completely destroyed tissue planes.
So moving down below the cricoid, we hit the trachea itself. Average adult length is about 11 centimeters, roughly 2 to 2.5 centimeters wide.
And it's supported by 18 to 22 of those U-shaped cartilages, half in the neck, half in the chest.
And that dual compartment layout becomes super important when we talk about deceleration injuries later.
Yeah, it relies on a really delicate segmental blood supply, mostly from the inferior thyroid arteries.
And the back wall of the trachea, that membranous part, is literally sharing a boundary with the anterior wall of the esophagus.
Which is exactly why tracheoesophageal fistulas are such a common and devastating complication of these injuries.
Okay, so with this entire fortress mapped out, let's look at a real-world scenario the authors describe. An unstable patient rolls in.
Right, they've got a massive neck hematoma, they're asphyxiating, SATs are dropping into the 60s.
And here's where the text challenges our core reflex. They explicitly state blind endotracheal tube placement is almost always a poor choice.
It really goes against our instinct, doesn't it?
It totally does.
Yeah.
I mean, if the patient is seconds from a noxic brain injury, why is pushing a tube down their throat considered a lethal mistake?
Well, it comes down to the mechanical state of the torn airway. Often, the fascia, or a tiny mucosal bridge, is the only thing holding the airways somewhat aligned.
So it's just hanging by a thread.
Literally. And if you take a standard endotracheal tube, especially with a rigid stylet, and force it blindly into a bloody edematous field.
The bevel of the tube basically becomes a weapon.
Exactly. The tip catches that fragile mucosal flap, and you instantly convert a partial tear into a complete transection. You just shear right through it.
Oh, man. But the actual mechanism of death isn't just the physical tear, is it? It's what happens when you hook them up to the vent.
That's the real executioner. The tube slides out of the true airway into the pretracheal space. You inflate the cuff, thinking you're in the trachea, and you start bagging.
So now you're pumping 100% oxygen under high pressure straight into the closed fascial spaces of the mediastinum.
The cascade is instant. You get this massive influx of gas that completely compresses the great vessels. Venous return drops to zero.
Tension pneumomediastinum and massive subcutaneous emphysema. The patient just codes from mechanical ventilatory failure.
Right, so to avoid that, the absolute mandate is visual confirmation. If they're stable, you do a bronchoscopic guided intubation.
Where you watch the lumen the entire way down. But what if they're actively dying and you can't see the cords from above?
Then you bypass the upper airway entirely. You do an awake tracheostomy or a cricothyroidotomy under local, securing it well below the injury.
That makes a lot of sense. So moving on to the diagnostic algorithms for the pharynx and larynx, because missing an injury here leads to awful late complications.
Yeah, let's start with the pharynx. Like we said, isolated blunt trauma is super rare here. It's almost always a gunshot, a stab wound, or an iatrogenic endoscopy injury.
And if it's a minor injury, the signs can be dangerously subtle, right? Maybe just some mild dysphagia.
But the severe ones give you aphonia, dyspnea, hemoptysis. The big physical exam red flags are oral bleeding, drooling, and subcutaneous emphysema.
If a patient has those but is stable, you go straight to imaging. You're looking for lateral cervical x-rays or non-contrast neck CTs.
And you are hunting for one very specific radiographic sign: retropharyngeal air.
Let's unpack that. How does the air actually escape the airway and end up behind the spinal column?
It's all about those fascial planes. When a bullet breaches the mucosa, it connects the high-pressure air digestive tract to the retropharyngeal space.
That potential space between the buccopharyngeal and prevertebral fascia.
Right. So every time the patient swallows or breathes, they drive air straight through that hole.
And because that space is just a highway down into the mediastinum, the air tracks vertically. On the X-ray, you see that dark lucency widening the space in front of the spine.
It's completely pathognomonic. And the authors stress you absolutely must get a contrast esophagogram or do an esophagoscopy to confirm the leak.
Because missing an esophageal tear means mediastinitis, which is almost always fatal.
Exactly.
Yep.
Now, moving to the larynx, the mechanics change. It's less than 1% of trauma, but the destruction is massive.
The text cites that classic Sheely study, noting 88% of blunt laryngeal injuries happen above the fourth tracheal ring, the classic clothesline injury.
Right. Picture a dirt bike rider hitting a wire. The wire catches the anterior neck, the body's momentum keeps going.
So the thyroid and cricoid are just violently crushed backward against the cervical spine.
The cartilages shatter, the mucosa is pulverized, you get stridor, hoarseness, hemoptysis, and you actually physically lose the thyroid prominence on palpation.
The neck just loses its normal shape.
Yeah.
Now, if they're stable with these signs, the ATLS diagnostic triad is strict. Fiber optic bronchoscopy, direct laryngoscopy, and a multi-detector CT angio.
Yeah, ideally a 64 to 256 slice scanner. The CT angio does two things. It maps the fractures, and it checks the internal carotids.
Because those carotids are right there and have a huge risk of dissection from the kinetic energy.
Exactly. And once you have the imaging, you use the Schaefer-Furman classification system to manage it. It's a 5-tier system.
Group 1 is just minor endolaryngeal hematomas. No fracture, architecture is intact.
Group 2 is visible edema, maybe minor mucosal tears, but strictly non-displaced fractures.
But Group 3 is the tipping point, right? That's severe trauma.
Yeah, massive edema, exposed cartilage, displaced fractures, and vocal fold immobility.
Group 4 is basically Group 3 on steroids, 2 or more fracture lines, or massive mucosal trauma needing a stent. And Group V is complete laryngotracheal separation.
The airway is literally discontinuous. Now, the treatment hinges entirely on this. For Groups 1 and 2, the text outlines a non-operative protocol.
Bed rest, soft diet, and IV dexamethasone, right? 10 milligrams every 8 hours for 24 hours.
Right, based on a cited series of 12 patients with a 50% success rate, returning to normal voice without surgery.
But as clinicians, we really need to look at the methodological limitations of that. An observational series of 12 patients is wildly underpowered.
Oh, severely underpowered. No control group, no blinding, and massive selection bias. They obviously picked the mildest cases for the non-op group.
And the physiological rationale for the steroids reducing edema has huge trade-offs in a multi-trauma patient.
It does. Systemic steroids heavily suppress the immune system and impair fibroblast proliferation,
which you desperately need for wound healing. So you're trading a potential reduction in throat swelling for a definitive risk of systemic infection.
Exactly. We really need large, multi-center randomized trials to validate that steroid protocol. But for Group 3, 4, and V injuries, there's no debate.
Surgical intervention is mandatory. Early open reduction and internal fixation, or ORIF.
You have to physically reconstruct the cartilaginous skeleton with microplates or wires and often place a stent to hold it open.
Because if you don't do it early, you guarantee chronic strictures and permanent aspiration risk.
But here's the tricky part of the algorithm. Say a patient rolls in with a severe Group 3 clothesline injury, but they have stridor and an expanding hematoma.
They're actively losing their airway. The algorithm says you need a CT scan to map the fractures. Do you send them to the scanner?
Absolutely never. You never send an unstable airway to the scanner. The first question is always, is there impending airway obstruction?
And if the answer is yes, you bypass radiology and go straight to the OR.
You do an awake tracheotomy under local, secure the physiology, and only then do you map the anatomy with a CT.
Secure the physiology first, map the anatomy second. That is a golden rule. So let's descend below the larynx now into the chest cavity.
Because the mechanics of tracheobronchial disruptions down here change completely. It's not a direct crushing blow anymore.
Right. The sternum protects the trachea from direct impact. It's all about internal pressure dynamics and deceleration physics.
The classic scenario is a high-speed car crash. The driver sees it coming, takes a deep breath, and bears down. A massive Valsalva maneuver.
The glottis snaps shut. Then the chest hits the steering wheel, violently compressing the thorax.
And Boyle's law kicks in. Thoracic volume decreases, so the pressure inside the trapped airway skyrockets.
Add in Laplace's law, while tension equals pressure times radius, and the membranous tissues literally just explode outward from the inside.
And at the same time, you have the rapid deceleration. The cricoid is anchored in the neck, so it stops instantly,
But the lungs in Carina are heavy and hanging in the chest. They keep moving forward.
which creates incredible longitudinal shearing force along the trachea. It's being pressurized and whipped back and forth simultaneously.
The text notes that most of these ruptures happen within 2 centimeters of the carina, where the shear stress is highest.
And they're mostly transverse tears. When vertical tears happen, they're almost always on that thin, posterior membranous wall.
To really ground this, the authors gave us 3 wild case studies. Let's look at case 1, the nail gun injury.
Mid-30s guy, shot in zone 2 of the neck with a pneumatic nail gun. He rolls in with respiratory failure, nails sticking out of his thyroid cartilage.
Instinct says explore the neck immediately, but they went non-operative.
Yeah, they use the OR to extract, not cut. They do an awake bronchoscopic intubation, mapped the nail's path, and made sure it didn't hit the esophagus.
Then they passed an 8mm tube over the scope, past the nail, and pulled the nail out under direct vision.
But the genius part is how they manage the hole in the trachea. They use the endotracheal tube as an internal stent.
By placing the inflatable cuff entirely below the laceration.
Right. Because if the cuff is above the hole, the ventilator just blows high-pressure air into the neck, causing massive emphysema.
But with the cuff below, the wound is isolated. The normal tissue pressure of the neck just seals the mucosa over the hole.
He was extubated on day 3, went home on day 5, totally fine, just a masterful use of equipment.
Case 2 is different, though. A stab wound to zone 2 in a 40-year-old man in severe distress.
They found a 2.5 centimeter transverse laceration right at the cricotracheal junction, the absolute worst spot.
He was crashing, so they had to tube him immediately in the ER bay.
Then they got a CT angio, took him to the OR, did the full endoscopic workup, and found no esophageal breach.
So they did a primary open repair, suturing the airway closed directly over an 8-French endotracheal tube.
Stented it for 4 days, put a drain in the pretracheal space, and he went home day 6.
Both of those are great localized injury management, but case 3 is the one that really blows your mind, the blunt trauma ARDS case.
The physiology here is incredibly daunting. 43-year-old woman, high-speed crash, massive bilateral pulmonary contusions.
Which evolve into severe ARDS within 24 hours. Her lungs are stiff. She needs huge vent pressures just to oxygenate.
And then a bronchoscopy reveals a 4-centimeter full-thickness tear in the distal right trachea extending into the main bronchus.
Normally, a 4-centimeter intrathoracic hole is an absolute indication for an immediate right thoracotomy.
But they were completely trapped. To repair it, they'd have to drop her right lung and do single lung ventilation on the left.
And her left lung is already decimated by ARDS. She would die of hypoxia on the table in minutes. Surgery was literally impossible.
So they had to treat a massive airway hole non-operatively, using only advanced ventilator settings.
They dropped her tidal volume to 350 milliliters, allowed permissive hypercapnia, and set the PEEP to 15 centimeters of water.
And against all odds, it completely healed in 7 days.
I mean, how does a gaping hole seal itself without sutures? We need to look at the exact criteria for non-op management here.
The rules are strict. The tear has to be less than a third of the circumference, less than 4 centimeters, well-opposed edges, no tissue loss, and no esophageal injury.
If you meet those, the healing comes down to ventilator physics. How does a tiny 350 milliliter tidal volume help?
It mitigates cyclic radial stretch. A normal 500 milliliter breath raises airway pressure and stretches the cartilage outward.
Which would just constantly rip a healing mucosal bridge apart, like picking a scab from the inside out.
Exactly. By dropping the volume, the peak inspiratory pressure plummets. The tissue edges just sit quietly together.
But obviously, tiny breaths mean you aren't clearing CO2, hence permissive hypercapnia.
Right. You intentionally let the arterial CO2 rise, accepting a respiratory acidosis down to a pH of maybe 7.2.
Because the alternative blasting the airway with pressure prevents healing. And what about the high PEEP of 15? Doesn't high pressure risk blowing out the repair?
It sounds totally backwards, but in severe ARDS, alveoli constantly collapse. Without high PEEP, you need massive driving pressure to pop them open every breath.
That cyclic snapping open atalic trauma creates immense shear force.
So the high PEEP acts as a constant pneumatic stent. It holds the respiratory tree continuously open, minimizing dynamic movement.
And because the mucosa has such rapid cellular turnover, holding it perfectly still lets it bridge a 4-centimeter gap in a week. Just phenomenal.
But when those strict criteria aren't met, which is most severe cases you have to operate, the decisions made in the OR dictate survival.
Let's talk about those surgical tactics, starting with incisions. For cervical injuries, you want a transverse collar incision about 2 centimeters above the sternal notch.
But the text gives a really terrifying warning for complete cervical transections. You must always have the chest prepped and the sternal saw on the table.
Ready for an immediate median sternotomy? Why? What's the nightmare scenario there?
If the trachea is completely transected, the lower part loses its anchor to the larynx.
And the chest cavity is a negative pressure environment.
Exactly. The negative pressure plus lung recoil can literally suck the distal stump down through the thoracic inlet, deep into the mediastinum.
They actually mention a case where it retracted 10 centimeters below the notch and 10 centimeters to the left, just vanished into the chest.
You absolutely cannot chase that blindly from the neck. You will shred major vessels. You have to crack the chest and get it from above the heart.
For injuries lower down, distal to the thoracic inlet, it depends on the carina. For tears near the carina, it's almost always a right posterolateral thoracotomy.
Through the fourth or fifth intercostal space, people always ask, why the right side?
It's pure anatomy. If you open the right chest and deflate the right lung, you have a perfect direct view of the distal trachea and carina.
The only thing in your way is the azygos vein, which you just ligate and divide.
But if you go through the left chest, the aortic arch is draped right over the whole area. It completely obstructs your instruments.
The only time you use a left thoracotomy is if the injury is strictly on the left side, more than 2 to 3 centimeters distal to the carina, away from the aorta.
And before you even make the incision, anesthesia coordination has to be perfect. Opening a chest with a massive airway leak is incredibly dangerous.
Right. You lose whatever ambient tissue pressure was containing the leak. You need single lung ventilation.
Normally, that means double lumen endotracheal tubes.
But double lumen tubes are huge and rigid.
Yeah.
Forcing them past a torn trachea can easily make the tear worse.
Which is why the authors highlight the Univent endobronchial blocker. It's such a cool device.
It really is. It's basically a standard single lumen tube, so it's much safer to insert. But it has a tiny secondary channel built into the wall.
Containing a steerable catheter with a little balloon on the end.
Right, so you intubate normally, then pass a bronchoscope down, find the leaking bronchus, and physically drive that little balloon down into it.
Inflate the balloon, plug the leak from the inside, and you isolate the injured segment entirely.
But sometimes you don't have time for the Univent. Sometimes you turn the patient onto their side for the thoracotomy, the mediastinum shifts, and the tear just blows wide open.
They lose all ventilation. SATs drop to 30% in seconds.
In that case, you just open the chest as fast as humanly possible, grab the severed bronchus, and the surgeon directly intubates the lung right through the surgical field.
The script tech literally hands you a sterile tube, you shove it into the open bronchus, and hook it up to sterile vent tubing. Organized chaos.
Once you had the airway secured, the technical repair pearls from Table 2 come into play.
First is debridement. You have to sharply debride any crushed cartilage back to healthy, bleeding mucosa.
Then you do a primary end-to-end anastomosis, usually with running monofilament absorbable sutures.
But the single most important detail, the one that determines their long-term outcome, is that all knots must be tied external to the lumen.
This is huge. If you tie the knot inside or use a permanent braided suture, you leave a foreign body in the airway.
And the local macrophages go crazy trying to wall it off, right?
Exactly. They form massive hypertrophic granulation tissue. An intraluminal granuloma grows inward, and months later, the patient comes back with severe stridor from the stenosis.
Keeping the knots on the outside eliminates that inflammatory trigger. Now, another pearl from Table 2 directly contradicts basic surgery training. Avoid searching for recurrent laryngeal nerves.
Yeah, that feels so wrong to read at first. But you have to think about the blood supply.
The trachea's blood supply comes from delicate lateral branches of the inferior thyroid arteries.
And the recurrent laryngeal nerve runs vertically right through the middle of that exact same vascular web.
So if you start meticulously dissecting the lateral neck, trying to find a 2-millimeter nerve in a bloody field,
you are methodically stripping away the entire blood supply to the trachea. You devascularize the exact tissue you're trying to heal.
the anastomosis will just break down and dehisce from ischemia. Plus, in all that crush injury, you're likely to accidentally cut the nerve anyway.
The lesson is surgical discipline. Stay incredibly tight on the anterior and lateral cartilage. Don't stray into the grooves. Healing the airway takes absolute precedence over finding the nerve.
That's a powerful point. But even if you walk out of the OR with a perfect repair, the ICU phase is a minefield.
The postoperative critical care really dictates the final outcome. Early on, you're terrified of mechanical failures.
Loss of airway is the biggest threat. If they pull their tube out or it gets blocked, reintubating blindly will just rip your repair wide open.
It has to be done over a flexible scope by the most experienced airway operator, period.
Another huge risk is tension pneumothorax. If an air leak overwhelms the chest tubes, they crash instantly. The text mentions digital decompression for this.
Yeah, if they suddenly drop their pressure and SATs, you don't have 5 minutes for a sterile chest tube kit.
You literally take a scalpel, make a hole in the fourth intercostal space, and thrust your gloved finger directly into the chest.
Pry the ribs apart, vent the pressurized air instantly, and save their life while you prep a formal tube. It's brutal, but necessary.
You'll also see massive subcutaneous emphysema. The air dissects into the face and neck. They blow up like a balloon.
It looks horrifying to families, but it's usually self-limiting. As long as there's no tension pneumo, the body absorbs it over a few days.
But the late complications are where long-term quality of life is decided. We talked about stenosis, which happens in up to 9% of cases.
It requires repeat bronchoscopies, balloon dilations, and this brings up the massive controversy around using steroids post-op.
Some surgeons advocate for systemic steroids to suppress the inflammation and prevent that structure.
But the counterargument is that steroids inhibit the collagen deposition you desperately need to make the anastomosis watertight.
So you might prevent a late stricture, but you risk an early catastrophic breakdown of your suture line.
Exactly. There's no randomized data to settle it, so it's a deeply individualized call based on the injury severity.
But the complication every surgeon truly fears is the tracheoesophageal fistula.
Oh, a TE fistula is a nightmare, a direct communication between the airway and the digestive tract.
How do you make sure you aren't missing a hidden tear in the anterior esophagus when you're staring at a ruined trachea in the OR?
Because if you miss it, it leads to fulminant mediastinitis from saliva and gastric contents, which has a staggering mortality rate.
So the protocol is strict. You have to circumferentially mobilize the cervical esophagus to look at it from all angles.
And you must use the methylene blue test. You pass an NG tube, inject dark blue dye under pressure, and watch your surgical field.
If you see even a speck of blue dye, you have an occult esophageal tear that requires a 2-layer closure before you even touch the trachea.
And even if you repair both perfectly, you now have 2 fresh suture lines resting against each other.
The inflammation can cause them to fuse and create a delayed fistula, so you have to introduce a biological barrier.
Right, you take a pedicled muscle flap like the sternocleidomastoid in the neck or an intercostal muscle in the chest.
Keeping its native blood supply, and you physically wrap it between the 2 repairs. It brings fresh blood flow and acts as a physical wall. Other late complications include vocal cord paralysis. Cricotracheal separation has a massive 60% risk of recurrent nerve injury,
leaving them with permanent dysphonia and aspiration risk. Though if the nerve is just stretched neuropraxia, it can regenerate over several months.
We also need to highlight internal carotid artery injuries from pharyngeal trauma.
Yet a minor impalement, like a kid falling with a stick in their mouth, can cause an asymptomatic intimal dissection of the carotid.
And days later, it thromboses and causes a massive stroke, which is why screening CT angio is mandatory.
The text mentions that repairing that surgically near the skull base is nearly impossible. But endovascular carotid stenting is becoming a viable option to tack down the flap.
Finally, let's talk numbers, mortality stats. The overall tracheobronchial mortality rate is generally cited as under 30%.
If they survive the scene and make it to the hospital, post-1970 data puts mortality under 9%.
Which really speaks to the power of these advanced algorithms. But laryngeal trauma mortality is still cited up to 40%.
And we can't forget that 80% of blunt tracheobronchial trauma patients die on the side of the road from asphyxiation.
It's a sobering reality. The 20% who make it to you require absolute non-negotiable perfection in management.
Absolutely. So let's synthesize the core takeaways for everyone listening. Number 1, method of airway control dictates survival.
Avoid blind, styleted intubation. Use awake bronchoscopic guidance or go straight to an awake surgical airway below the injury.
Number 2, if you try non-op management, respect the strict criteria. Less than a third of the circumference, less than 4 centimeters, well-opposed edges.
And leverage ventilator physics. Permissive hypercapnia, low tidal volumes, and high PEEP to mechanically stent the airway from the inside.
Number 3, Map your surgical exposures.
Oh.
Collar incision for the neck, but always have the chest prepped for sternotomy if the trachea retracts.
And remember, right posterolateral thoracotomy for intrathoracic tears to avoid the aortic arch.
Number 4, protect your work. Tie all knots external to the lumen to prevent granulomas.
Avoid nerve hunts to preserve the lateral microvascular blood supply, and use muscle flaps to physically separate tracheal and esophageal suture lines.
Those are the surgical pillars.
Yeah.
But you know, that brief mention in the text about endovascular stenting for carotid injuries really gets you thinking about the future.
It does. As bioengineering advances, you have to wonder how soon we'll see widespread use of covered, bioabsorbable airway stents replacing open surgical anastomoses.
Could the trauma OR basically turn into an interventional suite?
Mm-hmm.
Imagine skipping the massive thoracotomy and just deploying a stent via a flexible scope.
A stent that perfectly aligns the mucosa, secretes growth factors, isolates the tear from the vent pressures, and then just dissolves after 6 weeks.
It's totally plausible. Early iterations for benign strictures are already out there. It could completely change the morbidity of these injuries.
But until that tech is in every trauma bay, you still need the scalpel, the bronchoscope, the vent mechanics, and the anatomical blueprints we laid out today.
Because when you're staring down a traumatized, asphyxiating airway, nobody's handing you a magical solution on a screen.
You have to go in there and build the solution yourself.